There is a 180-day requirement for a notice before the emergency department is to close. There's a 90-day notice before the hospital can close. There's a 60-day notice for the skilled nursing facilities and a 15-day notice for the home health agency. We have given notice for the home health agencies to close. Those will close on the 31st of January. The patients in those services have been and are being transitioned to other local agencies so that their care continues to be provided. We have not given notice of closure for any other entity in the district. And I think that's very important for everyone to hear, that we have not given notice for any closure of the district entities. If we do give that notice, the public will see this information on our website. We'll actually have signage hanging in the clinics, in the hospital, and other public areas. It'll be on social media. It'll be very apparent exactly which services are going to close and the time that they will be closing. Currently, we have not given notice of closure for any of the services other than our home health agencies. We're required to have a plan and collaborate with the county services, the city services, the police, fire, EMS. I know that everyone's familiar with what happened in Madeira. They thought they had a plan in place, they thought they had a partner, and at the very last minute that didn't happen, and they closed. They didn't get to give a 180-day notice that the emergency department was closing. And it has caused a lot of stress on the surrounding counties, huge stresses on EMS, as you all can imagine. So as much as we don't want to think about this plan, we do have to have a plan in place so that we're not kind of caught, unprepared. So we do have to have a plan, and we talk about it a lot. Is on one minute we're looking in one direction and talking about how we're going to stay open, but at some point we have to put pen to paper and talk about what do we do if we're not successful in having a strategic partner and being able to stay open. So the plan that we talk about and what we will implement is, we've broken it down into 3 different phases. And currently we're in the midst of phase 1. And as we've talked about already, we have given notice of a closure of our home health agency. That is a service that was continually losing money, and we didn't see any opportunity for it to be profitable, and that the services are available elsewhere in the community. We'll continue to look at services that the district has for continual loss and inability to be profitable. We're looking at the services that we provide out in the community, that we also provide at the hospital, that perhaps we can scale back with. In our clinics, we offer some of the same services that we offer at the hospital, so we'll take a look at the operating hours of those clinics and the different services that we provide as a measure of scaling back and still being able to continue to provide the services, but maybe at a fewer hours. We do have our 2 skilled nursing facilities, which we currently have over 90 patients, 90 residents. And our goal for the skilled nursing facilities, rather than a closure around those skilled nursing facilities, is if we have to move through this process, is that we would more likely lease or sell those services. None of us on this team have been able to even wrap our hands or our brains around displacing those residents. And so rather than not having those services available, we will look at other options that will allow the facilities to remain in the community, even if it means that we were to sell them or to lease them. So that's, like I said, we're in our kind of phase 1 of our 3-phase plan, looking at scaling back services, and just evaluating everything that we do for our ability to be profitable. The second phase in scaling back services would include scaling back services that don't impact the hospital's licensure. So our hospital is licensed as a general acute care hospital. The hospital has to maintain 8 services, and there's nursing services, medical services, surgical services, anesthesiology, radiology, laboratory, dietary, and pharmacy services. So maintaining those services at the hospital would be, what our goal is prior to, in the event of closing the hospital. So if there are those services out in the community, perhaps those may be, again, scaled back, but leaving intact those 8 essential services that make up the general acute care hospital. We would move in the direction of stopping elective surgeries in the latter portion of the second phase, looking at decreasing the number of beds that we staff in the hospital. We have 15 med-surg beds, we have 4 ICU beds, and 6 maternity care beds. We would look at scaling those back. And then, of course, prior to the need for actually closing the hospital and closing those services, we would have to, again, have given the notification to the proper, through the proper channels, and then begin transferring patients that would need care after a closure, and redirecting patients that come through the emergency department to other facilities. So I just wanted to say again that in the event that we do not get emergency funding, that we're not able to find a strategic partner and be able to continue to provide services in the community, would be the only case, or would be the case when we would need to cease operations of the district. But again, we have not given notice, and we will continue to work on the strategies that have been discussed tonight so that we can continue to provide care for the patients and the members of this community. Thank you.
Now we move to the portion of your questions. I'm going to invite Mia to come up here in a moment, and she will go through the questions. I'm going to invite the panel to answer them from there, and you will decide who's going to say. We'll get through as many as possible. We have 35 minutes for this, and hopefully we'll get lots of good answers.
So first, we got a couple of questions asking what the business plan is moving forward and the plan to get out of the financial crisis. I think you've actually kind of just gone over that, so I think we can. Can I just
add something to that? So we have this immediate business plan, right, that I talked about. I do want to say we have also a master plan. It's kind of our dream, and we know what we need to extend the services in San Benito County. We've looked at that extensively as a team. We know how we can grow. We know which services would benefit the community, which services are missing from the community. That's still there. We still have that. Right now, we need to get out of this immediate crisis, and then we have another business plan to grow from there. But we don't have the capital, and we don't have the support right now. So we really have more than one business plan that I just think.
Okay. So what exactly is the difference between the original reimbursement agreement that resulted in HHH refusing to receive in-network compensation from Anthem Blue Cross, and the one that was approved on December 28th. If that's your mark.
We should talk about their compensation rates, as Anthem doesn't like to share it. I will say in general, of all the commercial agreements, they would have been on the end of not paying as much as some of the higher agreements. So that's why we went into the negotiation. We're glad we're back in the network, but as Mary pointed out earlier, unlike Stanford or a larger chain facility, we just don't have a negotiating power, a larger entity. But we're happy they work with us and we're back in our agreement. But it's still not where we would need to be.
Can you assure the public that fiscal changes are in place that would not result in the same fiscal crisis you're in should you find funding to continue operations?
That one, we are making every stride to, like I mentioned earlier, to do operational savings. Is there a 100% guarantee? There's not. Healthcare is very volatile, so we are making the fiscal changes that we can right now and ensuring we keep the services open. And like Barbara says, we're looking at reducing those as we go along. So, you think that answers?
Why has your board not considered resigning minus new board member Devin Pack due to the inability to fulfill their fiduciary duties to the community? Why should they be trusted in the future?
I'll answer that. I'm Jerry Vance, by the way. The board of directors has no plans of resigning. We are a governing board and give direction to administration. Our commitment to the community is to do everything we can to work with all the parties and stakeholders to provide health care. We have made changes when needed and will continue to work with the administration during this difficult time. We also agreed that the Hazel Hawkins can no longer stay independent and sustain services for years to come. We support and funding a strategic partner. We stand by all of our admin team, 100%. We have other board members here tonight that are showing their support, and I appreciate all the feedback that the community has, asked of us and has given us. And we're going to be here in the long haul. We're not going anywhere. So, when my term is up, then we'll see. But for the meantime, I'm here to support all of you.
Okay. The county has done a great job of managing their own fiscal affairs and has a reserve for emergency situations. How do you justify asking them to give you their entire reserves when you have not shown your ability nor have you presented a plan to gain public confidence?
I'll take that. So we went to the county in December for the advancement in our property tax. That was the amount we asked for, $10 million, was not their entire reserves. So we went asking for a portion of those reserves, again, an advancement in what they collect in the property tax as a secured repayment for them. But they did vote, like I said, to advance us the 1.1 million that we're due in April.
Do the doctors that are recruited and paid by Hazel Hawkins generate enough income for their salaries? Has anyone reviewed the professional component of the insurance contracts for the clinic dogs?
I'll take that one again. First and foremost, the doctors are everything to us. If we do not have the doctors, we do not have Hazel Hawkins. So I want to stress that we will not have the services that we offer this community if we didn't have our physicians. So when we look at the physicians and bringing them on board at their contracts, we can't just look to the services that they provide in the clinics. We also look at the services that they provide. Remember, they're the ones ordering imaging tests, lab tests. They're the ones that doing surgery in our surgery center. So we look at everything as a whole. And we appreciate the doctors being partners with us and doing everything they can to keep the hospital open. That's one thing. The other thing was the billing.
Has anyone reviewed the professional component of the insurance contracts for the clinic doctors?
Yes, we have. When I mentioned the audit with the billing, that was the very first area we looked at, was the clinic. So yes, we are looking at that.
All right. If you had to narrow down the hospital's 3 major areas of concern, what would they be and why?
Finances. Finances. What else more? Capital funding.
Capital funding. Yes, the cash.
Flow, the capital funding. It's expensive to run the district, and as it ages, it costs a lot more money to repair the district and to upgrade the district. And just staying in compliance will just cost quite a bit of money, and we just don't have those capital reserves. And we're also at a situation where we're not going to have bankers looking to lend us money, because when they review where we're at, it's revenue into the future is what they're taking into consideration. So we need a partner.
What do you think the hospital does really well?
So, as I said earlier, I've only been here a short time, but one of the first things that I noticed that was very unique about this organization is truly the care that's provided. The folks are taking care of their neighbors and their own family members on a daily basis. And it just lends itself to a very, very different kind of care that you don't see in other places. So, it sounds like a canned answer to say, oh, they give good care, but they do give very good care. And some of the supplemental programs that you've heard Mary and Mark discuss tonight, that we've borrowed money from these supplemental payment programs. Those payment programs and that supplemental funding exists because of programs that we take part in that are based on the quality of the care that we're provided. So the $3 million that we borrowed from CHFFA was $3 million that was basically awarded to us through a quality incentive program that is money that will be given to us at a later time, but is based on a lot of measures that are monitored through the care that's provided in our clinics, through the care that's provided in our maternity unit, throughout the hospital. So when I think of, we talk about borrowing this money, it's truly our money, and it comes from the fact that we give really good care.
Add something to that. In 2010, we joined an organization called the District Hospital Leadership Forum. It's an organization of acute healthcare districts. Our only purpose is to get funding for the hospitals, but for the Medi-Cal population. So in 2010, there were 45 acute care hospital districts working. Now there are 31 or 32. Also at that time, we were able to implement new programs, and we raised ourselves $30 million. Now we've raised over $330 million. It sounds like a lot, but for the inpatient care for Medi-Cal, the state has not given us a raise since 2012. So think about that. An entire decade has gone by, and we give raises, we have increases in supplies, we have so many factors we're dealing with, and the state has not added to their funding. So what happens with organizations we're working with, we're finding creative ways to get funding. So what happens is, in the past I've used the term an IGT, an intergovernmental transfer. We're literally in the biggest program, the Quality Assurance Fund tax. Hospitals are taxing themselves, sending this money to the state, Only the state can get a matching fund from CMS, from the federal government, and then that money is sent back to us. Basically, they also count the money they send back to us, what we put up as a gift from them. So it's double counting what they're funding to the hospital, but we are doing this on our own. The programs that are provided by the state are nowhere near the supplemental funding that's provided from the hospitals who are participating in this state. And everyone has that, and at some point, there have been articles with Korea Delta, how big they are. From July through September, they were losing almost $10 million a month. The main part of that reason was not in management, it's their population of Medi-Cal had grown. It had actually grown in excess of 60%. So they provide great care, but if the state is not paying you to take care of that population, you're just going to lose more funding. So we try so many different things to keep the hospital going, but there are a lot of areas we're not getting that assistance we should, or the direct funding we should get on the front end from the state.
Okay, we kind of answered this one, but I'm going to read it in case you want to change that anything. Is a sunset plan being developed or in existence for the current operations? What would be closed next and so on? What about emergency room, clinics, lab, etc.?
That's pretty much what I answered with my presentation.
Nothing to add to that then. Okay. Good. All right. Is an outside consultant providing services to the Hazel Hawkins board on financial advice and or review? And if so, what consultant?
Yes, we are working with several consultants. The district is working with the one I talked about, helping us find a partner is B. Riley. And they are experts in going out and helping hospitals find partners and strategic people to come in and either purchase, lease, do managed contracts. That's their business, that's what they do. So it's not just us with these efforts, but B. Riley is helping us do that. They're also our financial advisors. So when I talk about having very tight controls of our finances right now, we have financial advisors looking at money coming in and money going out on a daily basis. We also have our legal team helping us through this process.
If solvency is not established for the continuation of the hospital as it is today, is the option that St. Louis Hospital arrived at several years ago one that is available, where hospital assets and programs were out to bid, with Santa Clara County being the respondent or winner of the bid, and subsequently taking over St. Louis Hospital?
I don't want to speak for the county, so that in St. Louis's solution, the county is the one who came in and basically took over, purchased the hospital. They have the winning bid, like the question said. So I don't want to speak for the county. I don't think we should.
Thanks. Could an effort be made to expand the number of insurance companies that view HHH as an in-network provider? We need more than just Anthem.
We do, and we're always open to new agreements, but they have to offer for their rates an acceptable amount to pay for the cost of care. Again, being a smaller hospital, and we just can't take someone who's not going to pay for the cost of care. Then you're not making any money by volume. You're just losing money when they come in through the door. So we're open to contracting with anyone that comes in with a reasonable amount, and we are not in a position to subsidize the profits of an insurance company. Anthem's not our only commercial agreement. We have Cigna, United, quite a few other agreements. We don't have Aetna, and that's something probably 6 or 7 years ago that agreement was terminated. My door is always open. I periodically reach out to Aetna, but again, it'll have to be an agreement where both parties can win.
Can you possibly expand the number of services at the surrounding clinics? Thinking of the one at San Batista, possibly more income could be derived from additional service for patients who could use the clinics.
We are looking at all options. So it's important for us right now, if we're going to bring in a service, that we have a good return on investment. I'd like to see a business plan, a return on investment for that service. We can't just expand services. We do need some capital funds for some services, but yes, we are willing to expand. Right now, we need to get through this financial crisis, and when we do look at a service, we will have a good ROI to make sure that we are not going to be losing money.
The Health Trust has some level of obligation to help support health for San Benito County. Did the hospital reach out to the Health Trust, and what response was received?
The Health Trust,
It's the San Jose Health Trust.
Or is it the San Jose Health Trust?
the Santa Clara County.
Yeah, they're a nonprofit, and they're meant to provide services in our county.
In ours as well?
We haven't, I haven't spoken to them, but we have spoken to health facilities in Santa Clara County.
Thank you. Janet? Does the hospital board of directors and management believe the future of the hospital is to be an independent organization that's not affiliated with a larger health system like Kaiser or Sutter?
We mentioned this, we're not seeing a way for us to stay independent and stable for years to come. Could we find some quick solutions, maybe, and get us another couple years, potentially? But to stay sustainable, our goal is to do another 60 years. And we're not seeing a way to do that without a partner.
Okay. Other hospitals have received funding earmarks from the state, like Watsonville. Are we seeking similar support?
Yes, we are. We are. Again, we are working with legislators from the state treasurer's office, and we have a presentation in front of the governor. So we are looking for funding. Now, Watsonville was a different situation. We know that, and we've been told that. So we can't compare one hospital to another when we look at funding. We continue to work with them, be creative. We want to find a creative way and work together, collaborate.
This one has 3 questions. The first is, why is the CFO still employed? Why has there not been a forensic accounting analysis of the hospital's finances for the last 10 years? And who actually owns the hospital at this time?
The district owns the hospital, and our finances are audited every single year. So you can go back for the last X amount of years, and there is an outside organization that takes a look at our finances. Our financial advisors even told us today how clean the books are and how well those reports are. So that is my answer.
This is a long one. Has anyone considered the impact to county residents that will be in need of urgent care? If the hospital closes, they'll have to be sent via helicopter or ambulance to another county for care. Most residents don't have the resources for $100,000 air ride for medical care. So, you mentioned that in when you did your closure meeting, the cost for it and how that will be borne.
I think the question was, have we considered it? And yes, we consider it every day. We know what happens in that emergency department, and simply without that emergency department, it would be catastrophic. People's lives are saved every day in that emergency department. So our efforts to do what we need to do and what we can do to keep the hospital in place are because we know what would happen if it wasn't there.
Do we know which departments generate more money for the hospital, which ones struggle to generate money?
We do. It's difficult, and Mary has talked about it before, because you can say one clinic may look like they're losing money, but they're also generating all the referrals for radiology, for the lab. So it's looked at overall. We did isolate home health, and that decision was made. I can say as we speak now, the skilled nursing facility actually makes more than the acute facility. And again, it has to do with the way that service is reimbursed, and also the volume that is taken care of in the facility. So as a whole, it's more expensive to run the acute departments than it is to run the outpatient departments. And you're always going to have support departments. Support departments don't generate revenue, but they function to serve the nursing and the ancillary departments.
Right. What's the viability of seeking a parcel tax from the voters of San Benito County?
We're looking at all options, and we are meeting with the county on that. So currently, our property tax market makes us about a little over 2 million. So about 2 million. And remember, we have a $150 million operating budget. So 2 million is what we get. We will look and work with the county, work with whomever we need to see if we can increase the parcel tax. But I do want to say, not sure that that's enough to every single year to get us out of what a certain year may bring us. Last year was different than this year. Again, healthcare is very volatile. So to put $1 amount on what it's going to take to make us solvent isn't going to be the same dollar amount what's going to make us solvent next year, because things change. So we absolutely will look at doing that, but we want to be good stewards of the community's money.
Are you currently in contract with potential partners or in negotiation to be purchased?
We are not in contract with, for a purchase. We have folks interested in us, and we do have folks signing NDAs, non-disclosures, so which means that we can't talk about it. So, but again, this plan that we put in place, the strategy that we are using, so far so good, we are getting some interest.
And what purchasing restrictions, if any, have been imposed?
It depends on the deal. So not every deal is the same. I don't know if they're referring to Madeira, because there are certain things when hospitals combine or merge, the Attorney General can get involved, and that's what happened in Madeira. The Attorney General came in, put in some restrictions. So we are working with our legal team to make sure that we avoid anything that happened at Madeira. Again, not 100% guarantee, but what our legal team is saying right now, because we are a district, that we may not have to go through that process that Madeira did with the Attorney General. So we're hoping we have less restrictions in place.
Okay, and just one last question. What steps can the Board of Supervisors take that have not been taken already to keep the hospital open? You want me to answer that? So, you know, they have come a couple of times before the Board of Supervisors to ask for funding. I think at this point, part of the reason to share all this with you is, you know, they are your elected officials. And so what I would suggest is that you contact your elected officials, the council and the supervisors, to let them know what it is you want, because that will help them to decide what the next steps will be. I think that's it.
Thank you, Mia. Thank you very much. Panel, thank you. You can imagine over the last 2 or 3 weeks when we started putting the word out that we're going to do a forum, everybody thought for some reason that I had the answers. And I got some incredible phone calls, incredible letters. I have a beautiful letter here from a patient who was born at the old days of Hawkins Hospital and has done a lot of services at the present one. And it's a glowing 3-page, glowing just about her deep love of the hospital. I'll end it with her last line in a moment. But on the other side of the coin, I also got some very angry and upset patients, as you can imagine. People who felt that they didn't get the care for themselves or their mother. And that is a hospital. If somebody doesn't come out alive, sometimes we blame our doctors or nurses, and that will be every community hospital up and down the state. Your community foundation is part of a league called the California League of Community Foundations. There are 32 of us in California, and all over California, we're hearing these exact same issues, particularly in our rural communities, of struggling to keep their hospitals open. And as you know, if a hospital does close, the possibility of it reopening is very, very slim. It's much harder to reopen something and start something from scratch. So I have to commend the board, the staff, and the community for your outreach. Look, we would normally, if this was a different type of forum, there's 150 people here tonight, coming out on a cold night, by the way. So thank you very much. I will give you a little smile for my last little comment. So this lady wrote this incredible deep love of the hospital, and this was her last line to me. She says, "If you don't fight for this hospital, you will be long considered as the man who failed this community." That's a heavy responsibility. Yeah, the man who failed this. And you know what I've learned is, working with the community for many years, no one person can save anyone. We cannot, no one person. There's no savior coming in on a white knight. It is us, the community. It's our elected officials here locally. It's our elected officials in Sacramento. And it's also our elected officials in Washington. They're the ones who are going to help. If we can't keep our rural hospital open, it's not good for anybody. So there is coffee, there is cookies, no calories, and you're welcome to come up and visit with the panel. Thank you all for coming. Thank CMAC and also community. Thank you.